Evolution of Wechsler's Memory Scale. Content and Structural Analysis. Philip L. Kent. Private Practice. Bettendorf, Iowa. Abstract. The Wechsler Memory Scale 1 was introduced to the professional community 70 years ago and has been the most widely used standardized memory battery for over 50 years. Since its introduction, the test has been revised 3 times, with the last revision occurring in 2009. Few clinicians are aware that Wechsler developed a prior memory battery in 1917, which was used to assess retention deficits in persons with Korsakoff psychosis. The purpose of the present article is to describe the development of Wechsler's memory scale from 1917 through 2009. Suggestions for the next revision are offered. Keywords assessment, memory theory, test development, Wechsler memory scale. When in 1907 the American Psychological Association undertook through a committee the standardization of psychological tests, the effort was spent mainly on standardization of procedure. As a result, there were produced tests of a fair degree of technical merit. Now the pendulum is at the other extreme. The emphasis is on standardization of results. Less attention is often paid to the construction of the test as such. Wells, 1927. Perhaps the chief obstacle to a more rapid analytical development of tests has been the desire to express results in quantitative terms in order to establish norms for comparative purposes. To accomplish this aim, investigators have been forced to posit and assume that the particular test which they were standardizing tested only one quality, as memory, imagination, form perceptience, or rate of movement. If, however, the investigator was aware that other factors were involved, he failed to give them the prominence and emphasis necessary to prevent others from falling into the error of being content to assume that only one quality is being tested. Young, 1916. When a life history, assuming it to be accurate, is in disagreement with the psychometric, it is well to pause before attempting a classification on the basis of tests alone. Wechsler, 1939. The Psychological Assessment Workgroup of the Competencies Conference identified 8 core competencies in assessment. Childs and A., 2002, analyzed program materials and course syllabi from APA-accredited clinical psychology doctoral programs in relation to many of those competencies. 60% of programs covered validity and reliability. Reported in Reddy and B., 2014. Introduction. Nearly a century ago, Wells, 1927, criticized psychological tests for what would be described as their lack of construct validity. He was echoing, to a certain extent, the views of Young, 1916, who criticized test makers that pursued quantitative expression and standardization at the expense of content validity. Likewise, Wechsler, 1939, was critical of purely quantitative approaches to assessment, especially those which failed to take into account the person's life history. He was one of the earliest fighters in the battle between those who espoused a quantitative as opposed to a qualitative approach to assessment. In discussing the assessment of intelligence, he recognized that factors other than intellectual ability. Nearly a century ago, Wells, 1927, criticized psychological tests for what would be described as their lack of construct validity. He was echoing, to a certain extent, the views of Young, 1916, who criticized test makers that pursued quantitative expression and standardization at the expense of content validity. Likewise, Wechsler, 1939, was critical of purely quantitative approaches to assessment, especially those which failed to take into account the person's life history. He was one of the earliest fighters in the battle between those who espoused a quantitative as opposed to a qualitative approach to assessment. In discussing the assessment of intelligence, he recognized that factors other than intellectual ability, such as drive and incentive, enter into intelligent behavior. Even a cursory reading of his seminal book on intelligence, Wechsler, 1939, and his paper introducing the Wechsler memory scale. Wechsler, 1945, reveals that Wechsler was well aware that human behavior has multiple determinants. For Wechsler, assessment was more than just testing. As we shall see, theory, research, and clinical observation influenced Wechsler when he developed his instruments. Flash forward to the present. One would assume that all neuropsychological tests these days would be firmly anchored in an explicit theoretical base and be informed by our current understanding of brain-behavior relationships and evidence-based practice, that is, the best available research evidence bearing on which tests best identify the specific neuropsychological deficits of various clinical groups. Such is not the case. Contact Philip L. Kent at mc.com at mc.com 3630, Deer Springs Drive, Bettendorf, Iowa, 62722, USA. Copyright 2017 Taylor and Francis Group, LLC. One need look no further than the Wechsler Memory Scale 4, WMS4, 2009, which was published in 2009. It is not anchored in an explicit theory of memory, Kent, 2013, and the technical manual provides a relative paucity of information regarding how the test performs with various clinical groups. How is this possible? with all the push for theory and evidence-based practice in the past 20 years. All current training models in doctoral clinical psychology programs recognize the need for training in science. The models differ primarily in how much emphasis is given to training in research and the scientific sound data in psychology. At present, the dominant training model in clinical psychology, the practitioner-scholar model, primarily emphasizes preparation for a career in clinical practice. Murray, 2000. An unintended consequence of this model may be clinicians who are not well-grounded in basic psychometric theory, and who are thus unlikely to be able to intelligently read, understand, and critique test manuals. With the shift in emphasis on how most clinical psychologists are trained, there is evidence that interest in the history of psychology, and by extension, the history of ideas, is on the decline. The only doctoral program in the history and theory of psychology in the United States ended in 2009. Concerns have been expressed that we may be witnessing a decline in the number of psychology departments teaching courses in the history of psychology. Despite the decline in interest in the history of psychology, all APA-accredited programs require coursework in history and systems of psychology. By implication, it is implied that sound clinical practice dictates that practitioners have a working understanding of the theoretical foundations of the instruments they use and the domains they assess. For instance, if a clinician is using a test of memory, the clinician should be conversant with the theoretical found data of the test, which components of memory are purportedly being assessed, and why. To understand test construction, one has to be familiar with the concepts of reliability and validity, and how they are operationalized and measured. According to a recent study by Childhood Aid, 2002, of APA-accredited clinical psychology programs, only 60% of the programs surveyed covered validity and reliability when teaching psychological assessment. It appears that a significant number of psychologists practicing today are uninformed about these critical concepts, even though they are considered part of the core competencies in assessment. As a result of their lack of training, they may fail to appreciate the complex relationship between a test's reliability and validity, and fail to grasp that even though a test may be perfectly reliable, it may nonetheless invalid for the intended clinical use. Sternberg, 1995. This trend in training, that is, the lack of universal training in basic psychometric theory, is alarming, and does not bode well for the future of psychological or neuropsychological assessment. By the time the original Wechsler Memory Scale, WMS, was introduced in 1945, it had been in clinical use since 1940, Wechsler, 1945. By 1946, it was already among the top 90 most frequently used tests, Louder than Brown, 1947. By 1969, the WMS was the 19th most used test and the most used memory battery, Lubin, Wallace, and Payne, 1971, and by 1994, the Wechsler Memory Scale, revised, WMSR, was the 9th most used test by clinical psychologists and the 3rd most used test by neuropsychologists who conduct TED assessments 5 or more hours per week, Kamara, Nathan, and Fuente, 2000. By 2011, it was among the 10 most popular psychological tests taught in clinical psychology programs and the most frequently taught. Memory battery, Reddy and V, 2014. Suffice to say, the WMS has stood the test of time, despite ongoing concerns about its structure, lack of anchoring in an explicit theory of memory, and a variety of other concerns. Because the WMS has been in clinical use for over 75 years, it is doubtful the average clinician is aware of its historical roots, the theoretical rationale for its original content, and how it has evolved over time. As far as the present writer could determine, this is the first paper to trace the development of Wechsler's memory scales from 1917 through 2009. Since this article focuses on Wechsler's thinking about how to assess memory, special attention will be paid to the 1917, 1945, and 1987 scales, since these were the ones Wechsler directly developed. Wechsler, 1917, 1945, 1987. In 1946, a second version, the WMS2, of the test was published. Stone, Gerdner, and Albrecht, 1946. It is unclear if Wechsler was an author of the WMS2, since he was not listed as an author in the original paper describing the scale, although his name appears along with Stone's on the test manual. Since it is unclear if Wechsler was an author of the WMS2, the content of the scale will not be discussed. The Wechsler Memory Scale 3, WMS3, and Wechsler Memory Scale 4, WMS4, list Wechsler as author, although they were developed long after his death by a team of psychologists connected with Pearson Assessment, formerly the Psychological Corporation. Although the WMS3 and WMS4 were not developed by Wechsler, their content will be discussed to illustrate how the WMS has evolved over time, and to identify the problems that have plagued each revision. Due to space constraints, the WMS3 abbreviated form and the Applied Neuropsychology, Adult 233. WMS for older adult battery will only be briefly mentioned. In terms of method of investigation, the present article will review primary source material for Wechsler's 1917, 1945, 1987 scales and selected publications by Wechsler relating to his conceptualizations of memory. In regard to the WMS3 and WMS4, the analysis is based merely on a review of each scale's administrative and technical manuals and a clinical guide to the use of the WMS4. This paper will address the adequacy of assessment of memory, as exemplified by the Wechsler NEM-ORI scales, in light of what is considered good clinical practice. The terms text, scale, and battery will be used interchangeably. The term WMS will be used generically to refer to the scales bearing Wechsler's name, with 1R for revised, 3 and 4 referring to each version. Since other writers have discussed the limitations of the Wechsler scales in terms of reliability, validity, and standardization, these issues will not be discussed in depth. Since there is no current gold standard on how to assess memory, the following criteria will be used to assess the adequacy of each of memory scales discussed in this article. As the emphasis of the present paper is on the clinical assessment of memory, it is assumed the characteristics of an adequate assessment procedure should include the following. Prior to formal memory testing, a screening should be completed to ensure the subject has adequate sensory and motor functioning, is not aphasic or psychotic, and is sufficiently motivated to be tested. Lezak, Hoesen, Figler, and Tranel, 2012. As part of the screening procedure, attention should be assessed using any of the major models of attention, such as Mirsky, Koziel, Joyce, and Berglitz, 2014, to identify any deficits that might affect the subject's NEM-ORI functioning. After the screening is completed, it is assumed that the clinician will primarily assess episodic, declarative, or explicit memory. Registration for short-term and working memory should be evaluated in verbal and nonverbal modalities to determine the memory span of the individual and the capacity for the temporary storage and manipulation of information. Baddeley, Allen, and Hitch, 2011. In COD-ING, short-term learning and recall should be assessed through the immediate recall of verbally and visually presented meaningful material. Lezak et al., 2012. Retention of learned material should be assessed using measures of delayed recall of verbally and visually presented material via pre-recall and recognition paradigms. The 1917 scale. In 1917, David Wechsler published a paper based on his master's thesis, which investigated retention in 5 patients with Korsakoff psychosis. His study was notable because he identified a key deficit defining the condition, the inability to form new associations, and because he devised a verbal memory scale, which was a precursor to the WMS1. His test battery was designed to assess if defective retention in Korsakoff psychosis was due to 1. Impaired registration, 2. Defective encoding or a failure to link new associations with old, and 3. A fading of associations, or forgetting and retention problems. For Wechsler, retention was basically synonymous with memory. He defined retention as the ability to reproduce new impressions after a given interval of time. As part of the literature review to justify his method of study, Wechsler cited the works of Evan Goff, 1885, Brodmann, 1902, and other famous memory researchers and clinical investigators. His test was thus firmly anchored in the experimental and clinic. Cal research of the day, as indicated by the structure and content of his battery. As the reader is unlikely to be familiar with Wechsler's first memory battery, it will be described in some detail. The battery consisted of the following measures. Screening. A questionnaire was used to assess personal and current information and orientation. Registration. Auditory memory span for digits consisted of digit span forwards, beginning with a 4-digit series until 2 consecutive misses occurred. 3 lists were presented, memory span determined by averaging scores across 3 trials. Auditory memory span for unrelated words was assessed by measuring the subject's recall of 2 lists of concrete words. The lists ranged in length from 3 to 8 words. It should be noted that Wechsler actually stated the word lists ran from 4 to 8 words in his paper, and the maximum score was 66. For the maximum score to be 66, the word list had to run from 3 to 8 words. Prior to being read the word list, the subject was told how many words were in each list and that he or she was expected to repeat the words in the same order as presented by the examiner. 1 point was awarded for each word recalled, and 1 point was awarded if the word was recalled in correct order. The subject score was based on an average of the 2 lists. The word lists were obtained from Heil, 1913. Visual memory span for movement was assessed by administration of the Knox-Q test and the modified Knox-Q test. In the latter, the examiner touched 234p L10, 4 or 5 cues in a specific order, and the patient was asked to reproduce the specific sequence. Method of retained members consisted of the reproduction of two lists of 10 unrelated examples, red, dog, 5, and two lists of 10 related examples, river, water, brook, word lists longer than memory span. The word lists were obtained from Norseworthy, 1906. Each word list was read to the subject within 1 minute, and the subject was expected to repeat the word list. This subtest was similar in nature to a paired associates test, without the associates. Encoding. Formation of preformed associates was a paired associ 8 learning task. The subject was verbally presented a list of 10 word pairs, which were considered easy associ atesh, until the subject linked all the associates correctly or until 20 trials had elapsed. If subject supplied an incorrect associate, the examiner corrected the subject. 2 sets of word pairs were used. Formation of new associations was also a paired associated learning task and consisted of the learning of new paired associates, such as Questark and School Grocery. The lists of new paired associates were taken from an unpublished work of Oliver Woodward with some modifications. Wechsler used a list of 10 pairs of new or hard associates and a 5-pair list. The subject was administered the aforementioned word lists. Retrieval. Curve of forgetting for intervals of 15-inch, 30, 60, 1 foot, 3, and 10 assessing retrieval was accomplished through 3 procedures. 1. Recall of a series of digits after a single repetition. The digit series administered was unknown, but described as 1 digit shorter than the subject's memory span. The subject had to repeat them immediately after intervals ranging from 15-inch, 10 foot 12 observations were made for intervals 15, 3, and 6 observations were made for 10 efforts were made by examiner to prevent subject from reversing digits. 2. Recall of colors after a single presentation. The colors used for this procedure are unknown, except for colorblind subjects, where the colors red, green, blue, yellow were used. A color was shown and the subject was asked to name it. The method of presentation for colors was similar to digits. 3. Recall of single unrelated associates after 1 repetition. The associates used are unknown. The purpose of the procedure was to deter. Mind how fast the connection was lost between 2 unrelated associates established by a single repetition. Recall. Was tested at 15-inch, 30, 1 foot, and 3. 12 observations were made for all intervals except 1, for which 6 were made. Discussion. Wechsler's battery did not formally screen for aphasia or other conditions that would render his subject untestable, because the screening had been completed by the physicians who diagnosed and referred the patients to Wechsler for his study. Since Wechsler was conducting a research study, it is understandable he did not complete a formal screening procedure. Wechsler did, however, use a questionnaire to collect information regarding each subject's personal and current information and orientation. This information was qualitative and presented in his clinical description of the 6 patients, 5 with Korsakoff psychosis and 1 with general paralysis, presumably general paresis, who participated in his study. In regards to assessing registration, Wechsler's 1917 test was unusual in that it used several measures, recalling digits, unrelated words, and movements to accomplish this goal. Even though he noted that all tests were auditorily presented, the visual span for movement appears to have assessed visual working memory. It is unclear from his paper why he used the method of retained members, which consisted of assessing the subject's recall of word lists longer than their memory span. Wechsler spends very little time describing the procedure in his article, but does make a reference to Whipple, 1915, who describes this method as a measure of rote memory. Whipple, 1915, states that the length of series is chosen so the subject cannot attain complete mastery, and also notes that many span tests actually become tests of the degree of mastery, page 151. By this, he presumably means rote learning. The measures Wechsler chose to assess registration would currently be coincided measures of short-term and working memory. In regard to the method of paired associates, it is significant to note that he included preformed associates and new associations. Preformed associates contained word pairs which stood in some symbological relations and had been strongly established through frequency of previous association, e.g., Congo, lead pencil, metal iron. Wechsler, 1917, page 420. They are considered easy associates, and presently would be considered a measure of semantic memory. New associations, i.e. associates, were unrelated word pairs. Unrelated word pairs were used to assess if his subject could form new associations, which was felt to be the essence of encoding. New associates were considered hard associates. Wechsler wanted to test the hypothesis that people with Korsakoff might evince a difference in their ability to learn both types of word pairs, and applied neuropsychology, adult 235. Indeed, this was the case. He found that his subjects, i.e., persons with Korsakoff psychosis, performance on preformed associates was essentially normal, and their performance on new associates impaired. It is significant to note that the reasoning for his his inclusion of both word pair types, which were also used in the WMS-1, was not included in the 1945 test manual. The purpose for including both paired associate types appears to have gone largely unnoticed in the clinical literature on the WMS. The paired associates test was administered up to 20 trials, or until the subject was able to recall all the word pairs correctly, so it was in essence a paired associate learning test. Paired associate learning procedures were assumed to be an index of a person's ability to learn new information. Thorndike, 1908, noted that quick learners are good retainers, and Wechsler cited Thorndike in his study. As noted, Wechsler assessed retrieval/forgetting by examining the recall of digits, colors, and single associ. Atesh after one repetition, 1917. Wechsler was strongly influenced by the work of Ebbinghaus, 1885, in his effort to systematically assess retrieval/forgetting. He used multiple learning trials in time intervals up to 10 minutes to assess this process. Wechsler explicitly designed his 1917 test to be a verbal memory battery, since previous research had suggested that patients with Korsakoff's may have deficits in the range of visual perception. Wechsler, 1917, page 417. Interim summary: Wechsler's first memory battery was remarkably extensive. Based on the criterion for a sound memory exam discussed earlier, he used multiple measures, verbal and nonverbal, to assess registration or short-term and working memory, including a test to assess memory for words longer than memory span. He used easy and novel paired associate tasks to tease out the exact nature of encoding deficits, although he did not assess the delayed recall of visually presented material except colors. He systematically investigated forgetting/retrieval across intervals ranging from 15 seconds to 10 minutes, although he did not utilize recognition techniques. Nowhere in Wechsler's paper is there a reference to this theory of memory, if he had one. Despite this, his work was clearly anchored in the experimental and clinical research of the day. His descriptions of patients indicate that he differentiated between memory for old events and recent events, and he was aware that, even though he used a test called visual memory span for movement, because it was auditorily presented, it did not primarily assess visual memory span. His research was influenced by the Associationist School of Memory, as described by James, 1890. The Wechsler Memory Scale 1. Approximately 30 years after his first memory battery, Wechsler, 1945, introduced the Wechsler Memory Scale 1, WMS-1, to the professional community. He had released the Wechsler Value Intelligence Scale, WVIS, in 1939. During the time Wechsler was working on the WVIS, he was developing the WMS-1. Wechsler states he worked intermittently on the scale for 10 years, which suggests he began work on the scale in about 1935. According to Wechsler, he wanted a scale which was rapid, simple, and practical. The manual for the WMS-1 runs a scant 9 pages, and no data are presented about its reliability or validity. It should be remembered, however, that the test was developed during World War II, and was intended for the assessment of soldiers and sailors with head injuries. It is important to emphasize that Wechsler was a pragmatist when it came to test selection. Pragmatism, along with theory, guided his selection of WVIS and WMS-1 subtests. He wanted tests which were clinically useful, easy to administer, and which related to real-world behaviors. He was well aware of the need for tests to have ecological validity. In the introduction to the manual, Wechsler refers to the memory examination described in Wells and Martin, 1923, and Wells, 1927, which he considered unsuitable for clinical work, although he adopted the term mental quotient, MQ, for his scale from Wells. He described the mental quotient as being analogous to the intelligence quotient. Although Wechsler was developing the WMS-1 along with the WVIS, there is no mention of the former in his book describing the development of the WVIS, although he does reference his 1917 scale, Wechsler, 1939, page 68. Wechsler presented the following table in his book, which was based on a similar table by Wells, 1927. Table 1 presents Wechsler's review of the literature summarizing how various diagnostic groups had historically performed on some standard psychological tests. As we will see, he obviously used the table to guide his subtest selection, although this is not explicitly mentioned in his 1945 manual. The WMSI was comprised of 7 subtests. They will be briefly presented. Screening. Personal and current information. This subtest was derived from a standard mental status exam. 6 items are similar in nature to those used in the Wells and Martin, 1923, memory examination. Wechsler included this subtest to identify people with suspected aphasia and dementia. 236P. L. Kent. Orientation. This subtest was derived from a standard mental status exam. 5 questions were asked to assess the subject's orientation to place and time. Registration. Mental control this subtest consisted of 3 items: counting backwards from 20 to 1, counting by 3 beginning with 1 up to 40, and reciting the alphabet. Memory span this subtest was the same subtest used in the WBIS, with the exception that the maximum number of digits was limited to 8 forward and 7 backwards. It is similar to the auditory memory span for digits used in Wechsler's 1917 scale. Encoding. Visual reproduction this subtest was a measure of visual working memory, although it was verbally and visually presented. The content of the subtest was derived from the Binet scale and the Army performance test. The subject was presented 3 simple geometric designs, one at a time, for 10 seconds. After the design was removed, the subject was asked to draw the design from memory. This test assesses visual short-term memory as well as motor functioning. Logical memory this subtest consisted of the immediate recall of 2 verbally presented paragraphs consisting of meaningful material. The paragraphs were modifications of passages 1 and 5 of the Army Performance Scale, Government Printing Office, 1921. Associate learning this subtest consists of 10 paired associates, 6 were easy associates, 4 were hard associates. Subjects are given 3 learning and recall trials. The word pairs were derived from Wechsler's 1917 scale. Discussion. Wechsler was aware of the need to screen patients for suspected aphasia, dementia, and disorientation. He included questions designed to identify these conditions in the personal and current information and orientation subtests. Wechsler assessed registration through 2 subtests. Mental control is considered a measure of working memory. Wechsler, 1945, considered it to be harder than memory span and used it to assess cases of organic brain disease that are not too far gone but show defects which would not be made evident by simple rote memory items, pages 87 to 88. In his 1939 book, Wechsler noted that although digit span had long been used by psychiatrists as a measure of retentiveness, or the ability to learn new information, he cited research that indicated digit span backwards problems correlated with difficulties with attention and concentration. He also noted that a modest digit span forward capacity was associated with people with limited intelligence and certain organic conditions. Wechsler deliberately used the combined scores of digit span forward, rote memory, and backward attention to minimize the amount each contributed to the total score. Nonetheless, it appears he included both digit span forwards and backwards so clinicians could use these scores to assess different parameters of functioning, although this is not clearly stated in his 1945 manual. Wechsler likely assumed that users of his scale were familiar with the WBIS and had read his book describing the development of the test, since it was expected that each patient had to be administered the WBIS so IQMQ comparisons could be made. Table 1. Intellectual disabilities in different mental disorders as indicated by low score performance on different tests. Schizophrenia, general paresis, organic brain, syndrome Korsakoff, senile, dementia vocabulary, asterisk, X current information, XXX sentence repetition, X asterisk, X paragraph, recall XXXXXX digits forward, XXXXX digits backward, XXXXXXX easy associate. Applied neuropsychology, adult 237. Visual reproduction, in assessing the immediate recall of simple geometric designs after exposure of 10 seconds, appears to be a measure of the ability to encode and recall visually presented material. Logical memory assessed the encoding and recall of 2 verbally presented paragraphs containing meaningful information. The use of logical memory, or paragraph recall, techniques dated back to the 19th century. As noted, the associate learning subtest, previously called the formation of preformed and new associates, was derived from Wechsler's 1917 scale. The purpose of the subtest was to assess how quickly the subject could learn new information. Scores from the 7 subtests were added up to obtain a raw score, to which a constant was added based on the subject's age group. This weighted score was then converted to an MQ. Since the WMS-1 MQ had been standardized against the full-scale IQ of the WBIS, it was assumed that MQs significantly lower than IQs indicated memory dysfunction, an assumption that has been questioned in the literature. See, for instance, Dennis et al., 2009. It is noteworthy that Wechsler never explicitly stated how large the IQ-MQ disparity had to be clinically significant, although it probably was 1 standard deviation. As has been noted elsewhere, the WMS-1 has been extensively criticized for lack of information regarding its reliability and validity. Hall and Toll, 1957, Limited Standardization, LESAC, 1976, and a variety of other issues. The astute reader will note a striking correspondence between Table 1 and the content of the WMS-1. It is clear Wechsler chose subtests because the research and clinical literature suggested various clinical groups had defects in those domains. This use of the research and clinical literature was a procedure which would currently be called an evidence-based practice. In comparison to the 1917 scale, the two overlapped. In informally assessing auditory digit span and pairs. Associate learning. Both contain screening case tie-ins. Each assess the domains of registration and encoding. Factor analytic studies of the WMS-1 revealed it assessed two factors, memory and attention and concentration, Kirkcalwell, 1973. It was primarily a measure of short-term, episodic declarative verbal memory. Interim summary. In many ways, Wechsler's 1917 scale was superior to the WMS-1. Compared to the WMS-1, the 1917 scale did a more thorough job of assessing short-term MEMORI. In regard to encoding, although both batteries used the paired associates procedure, the 1917 scale consisted of many more learning trials. Up to 20 trials were administered, compared to 3 for the WMS-1. The 1917 also did a good job of assessing retention over time periods up to 10 minutes. The 1917 scale was more explicitly linked to the experimental and clinical MEMORI assessment literature than the WMS-1. Neither test was anchored in an explicit theory of memory. The WMS-1 did not present any data about how the test performed with various clinical groups, like people with dementia, head injuries, and so forth. The WMS-1 was designed to be a rapid assessment device to be used in clinical, as opposed to research settings, and it achieved that goal. It was developed at the same time as the WBIS, and overlapped in content, to some degree, with Wechsler's 1917 scale. Wechsler designed the test as a screening instrument, and its content was dictated by what was known about the cognitive deficits of people with various neurocognitive disorders, including schizophrenia, organic brain syndromes, Korsakoff. Due to alcoholism, general paresis, and dementia in per. Sons 65 or older. With the WMS-1, Wechsler evaluated registration or short-term and working memory using verbally and visually presented information. Encoding was assessed using visual reproduction, logical MEMORI, and paired associates. His test was notably deficient in not formally evaluating long-term retrieval. The WMS-1 was primarily a measure of short-term verbal memory. The Wechsler Memory Scale Revised. The WMSR was published in 1987, 6 years after Wechsler died, and 42 years after the publication of the original scale. According to the test manual, Wechsler was listed as author of the test because he was extensively involved in its revision. He began work on the revision in the late 1970s, and was responsible for the major changes in the instrument, Wechsler, 1987. By the time the revision was published, virtually every aspect of the original scale had received numerous and scathing criticisms. For example, the WMS-1 was criticized for lacking information about its reliability and validity, Cohen, 1950, Hall and Toll, 1957, standardization issues involving provisional and limited norms, Frigatano, 1978, scoring issues, Mack, 1986, and use of a memory quotient, Lawrence, 1984. The scale was also criticized for its lack of theoretical adequacy, and as it aged, its failure to reflect advances in its data. Knowledge about memory functioning and neuropsy. Show-logical functioning. Lisa, 1976, in discussing verbal memory and learning tests in general, wrote, "The examiner's choice of memory tests must depend more on his clinical judgment than on scientific demonstration that this or that test is most suitable for." 238 P. L. Kent. Answering the question under concern, page 356. Clearly, she was not talking just about the WMS-1. By the time the revision was published, it was estimated that the number of revisions or variations of the original scale exceeded 50, Kent, 1992. The most popular revision was that by Russell, 1975, which consists of immediate and delayed recall of the logical memory and visual reproduction subtests. Despite numerous criticisms in the professional literature, the original scale is still occasionally used for clinical and research purposes. For example, see Ardila, 1999. Between the original scale and its first official revision, there had been an explosion of knowledge in the fields of neurology, biology, and neuropsychology. Clinical neuropsychology had come of age, and major findings emerged about our understanding of memory, partly due to the pioneering investigations of Scoville and Milner, 1957, and their study of H.M. and the work. Penfield and Jaspers, 1954, on brain mapping. By the early 1980s, the neuroanatomical substrates of memory were being identified, Luria, 1976, Squire, 1982. Responding to many criticisms of the WMS-1, the WMSR was designed to assess memory for verbal and figural stimuli, meaningful and abstract material, and delayed as well as immediate recall, Wechsler, 1987. The WMSR contained a series of brief subtests, with each purportedly designed to measure a different facet of memory. The subtests are presented in the following sections. Screening. Information and orientation questions. This test was used for screening purposes and was not included in scoring. It contained questions about biographical data, orientation, and information from long-term memory. It included 7 slightly modified questions from the WMS1 and another 7 case times assessing orientation, hand preference, and sensory problems. Registration. Mental control. This subtest involved counting backwards from 20 to 1, saying the alphabet, and counting by threes from 1 to 40. It used the same items as WMS1 and was designed to assess overlearned material. It also assessed verbal working memory. Digit span. This subtest was similar to tasks on the original scale, except subjects began repeating a series of digits of forward and backward series that were 1 digit shorter than WMS1 version. The subtest assessed attention and verbal short-term and working memory. Visual memory span. This test was intended to be a visual analog of digit span. The subject was asked to touch a series of colored squares in a predetermined order, which had first been demonstrated by examiner. The test purportedly measured visual short-term memory. Encoding. Logical memory. This subtest consisted of the immediate recall of 2 verbally presented paragraphs of meaningful material. 1 paragraph was derived from the WMS1, the other was a new story. Verbal paired associates. The subtest contained the same paired associate learning used in the WMS1, with the exception that 8 rather than 10 pairs were admonies tiered. The 8 pairs consisted of 4 easy and 4 hard associates. 2 easy word pairs were eliminated to shorten the test. The examinee was given up to 6 trials to learn the pairs to the criterion of 1 perfect repetition. Only the first 3 trials were scored. Figural memory. The subject was shown a set of abstract designs, and after each set was removed, the subject was asked to identify the designs within a group of larger designs. The subtest appeared to assess learning and recall of visually presented material via a recognition paradigm. In constructing this test, it was assumed that the abstract stimuli would be difficult to verbally encode. Visual paired associates. This subtest was developed as a visual analog to verbal paired associates. The subject was required to learn the color associated with each of 6 abstract line drawings. To minimize the role of verbal mediation in memorize-attain and responding, the color names were not used in presenting the items or responding to them. Up to 6 learning trials were presented until the subject answered all 6 items correctly, although only the first 3 presentations were scored. Visual reproduction. This subtest was similar to the visual reproduction subtest from the WMS1. The subject was asked to immediately draw simple geometric designs following Applied Neuropsychology, Adult 239. A 10-second exposure. 1 item from the WMS scale was dropped, and 2 new added. The scoring was revised from the WMS1. Retention. Logical memory. This subtest consisted of a delayed recall trial 30 minutes after logical memory was administered. It assessed the delayed recall of the encoding of 2 paragraphs of verbally meaningful material. Verbal paired associates. This subtest consisted of a delayed recall trial 30 minutes after verbal paired associates was administered. It assessed the delayed recall of a person's ability to encode and retain easy and hard associates. Visual paired associates. This subtest consisted of a delayed recall trial 30 minutes after visual paired associates 1 was administered. It assessed the delayed recall of the encoding of visually presented abstract drawings. Visual reproduction. This subtest consisted of a delayed recall trial 30 minutes after visual reproduction was administered. It assessed the delayed recall of the encoding of simple geometric drawings and motor ability. Discussion. In general, the WMSR was a significant improvement over the WMS1. No longer was the WMS merely a measure of short-term verbal memory. The directions for administration and scoring were significantly improved. The WMS1 had been normed on approximately 200 males and females aged 25 to 50, to which a correction was added to extend its use to age 64. Remarkably, although the WMSR was normed on 16 to 74-year-olds, it used extrapolated norms for some age groups, and was based on a sample of only 316 people. The small norming sample was surprising, in light of the resources of the Psychological Corporation, the amount of time that had occurred until the first revision, and the popularity of the scale. As we have seen, the content was updated, an attempt to measure nonverbal memory was made, and measures of delayed recall were added. Although the manual presented data on WMSR scores with selected clinical groups, the group sizes were small and samples of convenience, thereby limiting the clinical usefulness of the information. This was unfortunate, since the manifest content of the scale had been significantly improved. Due to the addition of some new subtests, clinicians could now compute index scores for verbal memory, visual memory, attention and concentration, delayed recall. A general memory memory quotient, could also be computed, but it was only based on measures of immediate recall, a detail unlikely appreciated by many test users. In terms of content, the information and orientation questions were used for screening purposes and no longer entered into scoring, and the content of the SUT-test was revised to be more clinically useful. In regard to registration, the mental control and digit span subtests were carried over from the WMS-1 in revised form, and an attempt was made to measure nonverbal memory span in the form of the visual memory span subtest. Unfortunately, the new subtest had a significant verbal component, although factor analysis indicated it loaded on the attention and concentration factor, Wechsler. 1987, page 75, helping to provide validation for that index. Score. Assessing registration was significantly improved compared to the previous scale. In regard to encoding, the test now included purported measures of verbal and nonverbal memory functioning. Figural memory and visual paired associate ATESH 1 joins the visual reproduction 1, logical memory 1, and verbal paired associates 1 subtests. It is unlikely many users understood why Wechsler included both easy and hard associates in the paired associate learning subtest. As noted, easy associates were considered easy because they assessed what would presently be called semantic memory, or what some might call crystallized intelligence. Hard associates were felt to assess the essence of encoding, or new learning. While the WMS-1 assessed immediate verbal MEM-ORI, the WMSR was biased, on the surface, toward assessing immediate visual memory. Unfortunately, factor analytic studies discussed in the manual stage indicated that the WMSR consisted of only 2 PRI. MERI factors, a general memory and learning factor, and an attention concentration factor. Although the factor analysis provided support for the use of the general memory index, it did not support the assertion of the author that the test measured memory for figural stimuli, meaningful and abstract material, and delayed recall. A later study by Franson and Iverson, 2000, suggested the WMSR assessed 3 factors: learning and immediate recall of verbal and visual information, attention and concentration, and orientation and the ability to recall information from one's personal history. Once again, a delayed recall factor did not emerge. Retention was assessed through the 30-minute delayed recall of the verbal paired associates 2, logical memory 2, visual reproduction 2, and visual paired. 240p L. Kent. Associates 2 subtests. Each delayed recall subtest loaded on the same factor with its immediate recall counterpart, Wechsler, 1987, page 76. Thus, although the WMSR was a significant improvement over the WMS-1 in terms of manifest content and structure, the attempt to measure delayed recall was not realized. Interim summary on the surface, in terms of content and structure, the WMSR was a significant improvement over the WMS. The scoring and manifest content of the scale were improved. Purported measures of delayed recall were added. It was able to be used with a wider age group, 16 to 74 versus 20 to 64-year-olds. It was normed on a larger sample of individuals, 316 versus approximately 200. As we have seen, however, the WMSR suffered from a substandard norming procedure, as the standardization sample was pitifully small. In addition, the manual lacked good quality information about its utility and validity with various clinical populations, and factor analytic study reported in the manual did not support that it assessed delayed memory. In light of the aforementioned, it is perhaps not unexpected that a new revision would arrive on the scene a mere decade later. The first revision missed its mark. Wechsler Memory Scale 3. The WMS-3 was published in 1997. The instrument was developed by a panel of experts employed by or Consult ING with the Psychological Corporation. According to the administration manual, the revision was based on an extensive literature review and expert opinion, Wechsler, 1997. As can be seen from Table 2, there were 8 new subtests: Faces 1 and 2, Family Pictures 1 and 2, Word List 1 and 2, Letter Numbering Sequence, Spatial Span, 2 of which were optional, Word List 1 and 2. In addition, the Mental Control and Visual Reproduction 1 and 2 subtests, which had been part of the standard WMSR battery, were now optional. 3 subtests new to the WMSR were eliminated: Visual Memory Span, Visual Paired Associates, and Figural Memory. Needless to say, the WMS-3 was a major revision. It used a substantially larger normative sample based on the 1995 census, see Table 3. Like its predecessor, the new revision was responding to criticism of deficient norming procedures and concerns about content. The new revision was co-normed with the Wechsler Adult Intelligence Scale 3. The test was designed to yield so many scores that computer scoring was recommended, possibly in response to anticipated criticism of the time it took to administer and score the instrument. An abbreviated form of the instrument was published which reportedly cut the administration time to 20 to 25 minutes. The abbreviated form will not be discussed further. While scoring the WMSR was relatively easy, brief, and straightforward, scoring of the WMS3 was cumbersome and time-consuming and yielded a multitude of scores of questionable clinical significance. Kent, 2013. If the WAIS-3 or Wechsler Individual Achievement Test, WIAT, was also administered, as was often the case, the clinician could make a wide range of comparisons between WAIS-3 and WIAT and WMS3 scores. As the number of comparisons increased, so did the likelihood of finding of statistically significant differences. Again, the assumption was that if there was a significant discrepancy between performance on the WAIS-3 and performance on the WMS3, that is, the latter being statistically significantly lower, this suggests likely memory dysfunction. Researchers have strongly criticized the practice of making assumptions about discrepancies in functioning on IQ and test stuff. Memory, see, for example, Ardila, 1999. For the first time, the publisher split the technical manual, Psychological Corporation, 1997, apart from the administrative and scoring manual, Wechsler, 1997. Few clinicians who purchased the WMS3 prior to 2002 are probably aware that the technical manual was significantly updated in 2002, Psychological Corporation, 2002. In the first technical manual, the publisher asserted that a confirmatory factor analysis yielded 3 factors: 1. Immediate and delayed auditory memory, 2. Immediate and delayed visual memory, and 3. Working memory. This conclusion was retracted in the updated manual, which stated that factor analysis had failed to confirm the immediate and delayed distinct times. A confirmatory factor analysis by Millis, Molina, Bowers, and Ricker, 1999, revealed that the WMS3 yielded the following 3 factors: 1. Auditory memory, 2. Visual memory, and 3. Working memory. The WMS3 contains the following subtests. Screening. Information and orientation, optional. This subtest was similar to the previous version with the exception that one question was reworded. It was scored, but the score did not contribute to any index or composite. Registration. Letter number sequencing. This was a new subtest. A series of letters and numbers were verbally presented, and the subject was asked to Applied Neuropsychology, Adult 241. Table 2. Wechsler's Memory Scales Across Time. 1917 Scale. WMS1. WMSR. WMS3. WMS4AD. Screening. Questionnaire for personal and current information and orientation. Personal and current information orientation. Information and orientation questions. Information and orientation -O. Brief cognitive status exam includes mental control O. Registration. Auditory memory span for digits, auditory memory span for unrelated words, visual memory span for movements, method of retained members, digit span mental control. Digit span mental control, visual memory span. Digit span O. Mental control O. Letter number sequencing, spatial span. Spatial addition symbol span. Encoding. Formation of preforms and new associations. Associate learning, logical memories, visual reproduction. Verbal paired associates, 1 logical memory, 1 visual reproduction, 1 visual paired associates, 1 figural memory. Verbal paired associates, 1 logical memory, 1 visual reproduction, 1 O. Faces I family picture, 1 word list, 1 O. Verbal paired associates, 1 logical memory, 1 visual reproduction, 1 designs, 1. Retention. Curve of forgetting for intervals using digits, colors, associations. Verbal paired associates, 2 logical memory, 2 visual reproduction, 2 visual paired associates, 2. Verbal paired associates, 2 logical memory, 2 visual reproduction, 2. O. Faces 2 family pictures, 2 word list, 2. O. Verbal paired associates, 2 logical memory, 2 visual reproduction, 2 designs, 2. Note. Core subtests in bold, optional subtests identified by O. New subtests italicized. 242. Repeat back the series, stating the numbers first, in order from lowest to highest, and then the letters in order. The sequences ranged from 2 to 8 items, and 3 trials were presented for each series. The test was discontinued after the subject failed all 3 trials with an item. This subtest measured verbal working memory. Spatial span. This was a new subtest. The subject was asked to exactly reproduce a series of tapping sequences on an array of blocks, which were first demonstrated by the examiner. The series ranged from 2 to 9 blocks for the forward and backward sequences. 2 trials were administered for each series. The test was discontinued when the subject missed both trials of spatial span forward and spot tile span backwards. Spatial span was a measure of visual working memory and procedural learning. Digit span, optional. This subtest is identical to the WAIS 3 version and was slightly modified from the WMSR. Subjects were asked to repeat a series of digits ranging from 2 to 9 forward and 2 to 8 backwards. Digit span forward was considered a measure of attention and short-term verbal memory span. Digit span backwards was considered a measure of working memory. Mental control, optional. This subtest contained 8 items like counting backward from 20 to 1, saying the alphabet, and saying the days of the weeks backward. This subtest was expanded considerably from the WMSR. It measured verbal working memory. Encoding. Logical memory won this subtest consisted of the immediate recall of 2 verbally presented paragraphs of meaningful material. Story A from the WMSR was retained, with slight rewording, and a new paragraph was devised which was more neutral in emotional content than its predecessor. There were slight modifications made to the scoring procedure. Faces won this with a new subtest. Each subject was presented a series of 24 faces to remember. The subject was then Table 3. WMS age ranges, number of subtests, and norming procedures. Age range hashtag subtests. Time between immediate and delayed subtests. Testing time, minutes, does not include scoring time norming 1917 scale not applicable 7 not applicable 30 not normed WMS 1, 1945. 20 to 64 7 not applicable 15 approximately 200 normal males and females aged 25 to 50 used extrapolated norms to extend age ranges. Memory quotient scores derived from comparison with WBA's WMSR 1987 16 to 74 13 asterisk 30 minutes 45 to 6,316 people based on 1980 census. Norms for 18 to 19 years old, 25 to 34 years old, and 45 to 54-year-olds were estimated. Approximately equal numbers of males and females. Subjects selected based on race, white versus non-white, geographic region, education, IQ based on WAIS-R WMS 3, 1997, 16 to 89 10 primary 7 optional 25 to 35 minutes, 100 asterisk asterisk 1032 based on 1995 census. Weighting procedures used to extend sample to 1,250. Subjects selected based on age, sex, race/ethnicity, educational level, and geographical region. Co-normed with WAIS 3 WMS 4, 2009. 16 to 90 12 primary 1 optional asterisk 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 20 to 30 minutes 65 80 asterisk 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 1400 co-normed with WAIS 4 representative sample based on 2005 census co-normed with WAIS 4 asterisk the WMSR information and orientation questions not scored. Administration of complete WMS 3 battery. The WMS 4 brief cognitive stack exam scored, but results not used to calculate any index score. Also, the CDLT-2 could be administered to obtain the auditory memory index and supplement the immediate memory index and delayed memory index in the WMS-4 adult battery and older adult battery. Time to administer, including the 20 to 30 minutes needed between immediate and delayed subtests. Applied Neuropsychology, Adult 243. Presented a series of 48 pictures, which contained the 24 pictures the subject was asked to remember, and 24 foils. The subject was to identify the faces he or she was asked to remember. This task involves the learning and recall of visually presented faces using a recognition format. Verbal paired associates won this subtest contained 8 new word pairs of hard associates. The subject was read a total of 8 word pairs, 1 word pair every 3 seconds. During the recall phase, the subject was read the first word of each pair and asked to provide the correct associate. If the correct associate was not provided in 5 seconds, the correct response was provided. For learning trials were given. This subtest was a verbally presented associative learning task. Family Pictures won this with a new subtest. The subject was shown a series of 4 drawing of family scenes, one at a time, for 10 seconds each, and told to study the picture and remember as much as possible about the scene. After all 4 pictures were viewed, they were removed and the subject was asked to recall who was in each picture, where they were in the picture, and what they were doing. The test purportedly measured the immediate recall of BISU ally presented, complex meaningful information, and spatial memory. This test was designed to be a visual analog of the logical memory subtest. Word lists 1, optional, this was a new subtest. It consisted of a list learning task similar in nature to the California Verbal Learning Test. The subject was read list A, which consists of 12 unrelated words and asked to recall as many words as possible. For learning trials were presented for each trial. The subject was then read another word list, list B, which consisted of 12 new unrelated words and asked to recall as many words as possible. The subject was then asked to recall as many words from list A as he or she could. This test measured the recall of a word list after an interference task. It assessed the temporal recall of verbally presented information. Visual reproduction 1, optional. Similar to previous versions, the subject was asked to draw a visually presented design from memory. The subtest was expanded to 5 designs, with several designs retained from the WMSR. This subtest purportedly assessed visual short-term memory of simple geometric designs. Retention. Logical memory to this subtest consisted of the delayed recall of the encode ing of 2 verbally presented paragraphs of meaningful material. It was administered 25 to 30 minutes after logical memory 1. Recognition memory was assessed through asking the subject a series of yes and no case times about each paragraph. Phases 2A total of 25 to 35 minutes after the administration of phases I, the subject was presented 48 pictures, 24 of which were the original phases to be remembered. The subject was asked to identify the 24 phases he or she was asked to remember for phases 1. This task involved the delayed recall of the encoding of visually presented phases using a recognition format. Verbal paired associates 2 after 25 to 30 minutes, the subject was presented the first word of each word pair used in verbal paired associates 1, and asked to provide the correct associate. A recognition test was then presented, 24 word pairs were read. The subject was then asked to answer yes or no if the presented word pair was one of the original word pairs used in verbal paired associates 1. This subtest may assure the delayed recall of the encoding of verbally presented paired associates via free recall and recognition format. Family Pictures 2A total of 25 to 35 minutes after administration of Family Pictures 1, the subject was asked to recall as many pictures as possible, who was in the picture, and where they were located. This task was a delayed recall measure of the encoding of visually presented complex meaningful information and spatial memory. Word List 2, optional, a total of 25 to 35 minutes after the administration of Word List 1, the subject was asked to recall as many words as she or he can. This task measured the delayed recall of the encoding of a verbally presented word list. A recognition trial was then administered, 24 words were read, which contained the 12 words presented in Word List 1 and 12 new words. The subject was asked to answer yes or no if the word was part of the original list. Visual reproduction 2, optional, administered 25 to 35 minutes after visual reproduction 1, the subject was asked to draw the 5 designs from. 2:44 p.m. Kent. Memory. The subtest presumably measured the delayed recall of the encoding of visually presented information. The subtest also contained a 48-item recognition task, a copy task to screen for motor dysfunction, and a 7-item discrimination task. Discussion. As can be seen from the aforementioned information, the WMS-3 was a significant revision of the WMS. Although the administrative and scoring manual stated it had 6 primary and 5 optional subtests, it actually had 12 primary subtests, assuming the delayed versions of the primary subtests were administered. Screening was accomplished through the information and orientation subtest, which unfortunately was now an optional procedure. The subtest could be scored. In regard to registration, the digit span and mental control subtests were now optional. They were standard procedures in the WMSR. Working memory was now primarily assessed via letter number sequencing, a measure of verbal working memory, and spatial span, presumably a measure of visual working memory. Encoding was assessed through the administration of logical memory 1 and verbal paired associates 1, as in the WMSR. In addition, 2 new primary measures were introduced, Phases 1 and Family Pictures 1. Visual. Reproduction 1 was now an optional subtest, and the WMS-3 introduced another optional new subtest called Word List 1, which was similar to the California Verbal Learning Test. Retention was assessed through Logical Memory 2, Phases 2, Family Pictures 2, and Verbal Paired Associates 2. If administered, retention could also be assessed through Word Lists 2 and Visual Reproduction 2. On the surface, the content of the WMS-3 met the criteria established earlier for an adequate clinical assessment of memory, assuming one administered the information and orientation subtest. The problem is, what the test purported to measure, and actually measured, did not correspond. As noted, like the WMSR, factor analysis revealed that the WMS-3 did not assess delayed recall, see Table 4, although it did assess auditory, visual, and working memory. Although the publisher acknowledged that the WMS-3 did not assess delayed recall, it nonetheless recommended the continued use of the immediate and delayed index scores on the basis of both clinical and theoretical considerations. Psychological Corporation, 2002, page 102. This recommendation was remarkable for a field which had been urging its practitioners to engage in evidence-based practice for at least 2 decades. 2 other major problems with the WMS-3 were the amount of time it took to administer the battery. About 100 minutes if the entire battery were given, and the amount of time it took to score the test if a computer-based scoring program was not used. Interim summary: although improved on the surface, the WMS3 was still much the same test it had always been if one looked strictly at factor analytic studies of the WMS1, WMSR, and the WMS3, see Table 4. On the surface, like its predecessors, it screened for sensory dysfunction and disorientation, which could invalidate the test results. It evaluated registration and encoding, and attempted to assess retention, although it failed in this regard, such as the WMSR, using supporting factor analysis studies as a criterion of success. The WMS3 introduced a number of new subtests, none of which were retained in the WMS4. Like its two predecessors, verbal paired associates and logical memory were part of the core battery. Mental control, visual reproduction, and digit span were also retained, but were now optional pro stewards, see Table 3. An abbreviated version of the scale was marketed, which significantly reduced the agonies. Tration time, but its use limited the amount of clinically useful information available to the examiner. As noted, the technical manual was split off from the Administrat eBay and scoring manual. A myriad of new scores of questionable clinical utility could be derived and comparisons made to scores from the WAIT-3 and WIAT. Scoring the WMS3 almost mandated the use of a computer-based scoring system. The length of time it took to administer and score the test decreased its clinical usefulness. In light of the aforementioned findings, it is perhaps not surprising that the WMS4 appeared 12 years later. WMS4. Like the WMS3, the WMS4 was revised based on multiple concerns about its predecessor. In brief, the Table 4. Selected factor analytic studies of the Wechsler memory scale. Battery factor analysis results 1917 scale not completed WMS12 factors, memory, attention/concentration, Kirk-Hallwell, 1973, WMSR3 factors, learning and immediate recall of verbal and visual material, attention and concentration, orientation and ability to recall information from one's personal history, Franson and Iverson, 2000, WMS33 factors, auditory memory, visual memory, working memory, Millis et al., 1999, Psychological Corporation, 2002, WMS43 factors, auditory memory, visual working memory, Holdnack and Drozdick, 2009, 2 factors, auditory learning/memory and visual attention/memory, Holz et al., 2011. Applied Neuropsychology, Adult 245. WMS3 was criticized as being too long, especially when testing seniors, lacking factor analysis support, especially for the visual memory index, difficulty with subtest administration and scoring, and the question-able content of several new subtests, Drozdick, Holdnack, and Hilsebeck, 2011. In addition, there were concerns about the reliability and the validity of some subtests, Pearson, 2015. Like its predecessor, the WMS4 was revised using a team of assessment experts associated with Pearson, Wechsler, 2009. Reviews of the psychometric literature on shortcomings of the prior instrument were completed, customer service data examined, and a panel of researchers and experts on memory were consulted to shape the new instrument. Compared to the WMS3, the WMS4 technical manual contains more information regarding the scale's linkages to the burgeoning literature on memory assessment and advances in our knowledge of the neurology. Cal underpinnings of memory functioning. The authors of the scale clearly attempted to link theory with track types, although the new scale, like its predecessors, was not based on a clearly articulated theory of memory. A training video on how to administer the test was developed, and supplemented by webinars on the test development and administration. Scoring of some subtests was revised. The new scale includes an adult battery for persons 19 to 69 and an older adult battery for persons 65 to 90. A person who is 65 can be administered either battery, although the latter is shorter because it contains fewer subtests. Designs 1 and 2, spatial span, and symbol span are not administered. In addition, several alternative batteries have been devised for special evaluations. Tablet-based administration is available. Computerized scoring has been enhanced. For the first time, the California Verbal Learning Test 2 scores can be used in place of scores from the Verbal Paired Associates 1 and 2. The manifest structure of the WMS changed once. Again, see Table 2. 3 new subtests were added: spatial addition, symbol span, designs 1 and 2, 3 were revised, logical memory, verbal paired association, and visual reproduction, and 8 subtests were eliminated: information and orientation, spatial span, mental control. It was rolled into an optional brief cognitive status exam, digit span, letter number sequencing, family pictures, word list, and visual memory span. For the first time, verbal working memory is not assessed. Instead, only visual working memory is assessed through the spatial addition and symbol span subtests. The WMS4 has 5 index scores: auditory memory, visual working memory, immediate memory, and delayed memory. Unfortunately, factor analytic studies have once again not supported separate immediate and delayed index scores. Some factor analytic studies have indicated the scale has either a 3-factor structure consisting of 1. Auditory memory, 2. Visual memory, and 3. Visual working memory, Holdnack and Drozdick, 2009, or a 2-factor structure consisting of 1. Auditory learning/memory, and 2. Visual attention/memory, Hull, Nelson, and Smith, 2011. The repeated failure of the WMS to assess delayed recall has been noted by several researchers. According to Holmes et al., 2011, this failure is due to a significant shared variance between immediate and delayed MEM-ORI tasks, and is consistent with psychometric theories of cognitive ability based on factor analytic studies like that conducted by Carroll, 1993. It should be noted that other popular tests of memory which purport to assess delayed recall also suffer from this problem. 4. Instance, studies of the California Verbal Learning Test 2 yield 6 factors, none of which is delayed recall. One of the factors, general verbal learning, is composed of several measures of level of immediate and delayed recall and recognition, Strauss, Sherman, and Screen, 2006. In a recent study of immediate and delayed memory for verbal and visuospatial information involved ING over 100,000 verbal and visuospatial immediate and delayed tests presented via the internet to over 28,000 participants ranging in age from 11 to 80. Factor analysis yielded an immediate but not a delayed dimension, Murr, Jansen, Raw, and Meter, 2013. Findings such as these along with research involving brain imaging have questioned the relationship between immediate and delayed recall, and whether it is possible to assess delayed recall, at least as it has been conceptualized. The WMS4 adult battery contains the following. Subtests. The procedures described in the following section were adapted from descriptions by Drozdick et al., 2011. Screening. Read cognitive status exam, optional. This subtest was derived, in part, from the information and orientation and mental control subtest of the WMS3. It was significantly revised and renamed, and includes measures of orientation, time estimation, mental control, clock drawing, incidental recall, inhibition, and verbal production. The test results are quantifiable, and norms are available based on one's age and level of education. The subtest is the same for the adult and older adult batteries. 246p L. Kent. Registration. Spatial addition. This subtest is a measure of visual and spatial working memory. It is a subtest based on the NBAC procedure. In brief, the subject is shown 2 grids, each for 5 seconds. Each grid contains a red and slash or blue circles, and the subject is told to pay attention to where the blue circles are located across the grid, while ignoring the red circles. The subject is asked to mentally combine the blue circles across the grids. The subject is expected to reproduce the combined grid by placing a blue card on the appropriate cell on the record form. Symbol span. This subtest is another measure of visual working MEM-ORI and the mental manipulation of visual details. The subject is shown a series of designs for 5 seconds and asked to recall and select the correct designs in sequence from a larger array of designs. Encoding. Logical memory 1. This subtest consists of 2 verbally presented stories. After the presentation of each story, the subject is instructed to retell the story, starting at the beginning. This subtest assesses the encoding and immediate recall of 2 verbally presented meaningful paragraphs. Verbal paired associates 1. The subject is administered a list 14 paired associates, 4 of which are easy and 10 of which are hard. The word pairs are administered in varying order. The subject is then given the first word of each word pair and is expected to provide the correct associate. 4 word pair trials are given. This is a classic associative learning task of verbally presented word pairs, and assesses the encoding and immediate recall of semantically related and unrelated word pairs. Visual reproduction 1. The subject is presented 5 designs, one at a time, and asked to draw each design immediately after its presentation. Each item is presented for 10 seconds. This subtest assesses the encoding and immediate recall of simple geometric designs. Designs 1. For this subtest, the subject is shown a grid with 4 designs in the grid cells for 10 seconds. A blank grid and 8 cards are then given to the subject, and the subject is expected to select the correct cards and to place them on the blank grid in the same array as demonstrated earlier. This procedure is repeated 4 times with 4 new grid patterns. This test assesses the encoding and immediate retrieval of visual details and visual spatial locations of geometric designs. For detailed instructions on test administration, please consult the test manual. Retention. Logical memory 2. Administered 20 to 30 minutes after logical memory 1. This subtest assesses the delayed encoding and recall of two verbally presented meaningful paragraphs. Verbal paired associates 2. Administered 20 to 30 minutes after verbal paired associates 1. A delayed recall measure is given of the 14 word pairs. A recognition test is then administered in which the subject is asked to correctly identify the 14 word pairs out of a list of 40 word pairs. This test assesses the delayed encoding and recall of semantically related and semantically unrelated word pairs using free recall and recognition procedures. Visual reproduction 2. Administered 20 to 30 minutes after visual reproduction 1. This subtest assesses the delayed encoding and recall of simple geometric designs. It also has a recognition procedure and optional copy procedure. Designs 2. This test is administered 20 to 30 minutes after immediate recall and contains a recognition trial. The subject is asked to recreate the 4 designs he or she was shown during Designs 1. This measure assesses the delayed encoding and recall of visual details and spatial locations of geometric designs. Discussion. This discussion will concentrate primarily on the content of the adult battery, listed in the previous section. In regard to screening, the brief cognitive status exam. Applied Neuropsychology, Adult 247. Remains an optional procedure, and it has been considerably enhanced compared to the WMS3 version. The results are quantifiable and provide some information about the subject's functioning. As noted, norms are available to analyze the subtest scores based on the subject's age and level of education. Registration is assessed through 2 new subtests, spatial addition and spatial span. No attempt is made to measure verbal working memory. It is significant to note that if a poorly trained examiner used only the WMS4 to assess working memory, information critical to many individuals' functioning might be missed. This situation could occur, for instance, for Social Security disability examinations when an applicant alleges MEM or problems. In the region where the present writer practiced, sometimes these examinations are completed by a subdoctoral school psychologist under the purview of a doctoral level psychologist. Encoding is now assessed through 4 subtests. 2. Assessing auditory memory, logical memory 1 and verbal paired associates 1, and 2 assessing visual memory, designs 1 and visual reproduction 1. If the California Verbal Learning Test 2 is administered before or after the WMS4, then scores from that instrument can be substituted for scores from the verbal paired associates 1 and 2. Retention is assessed after a period of 20 to 30 minutes through administration of the delayed versions of the subtests administered during the encoding phase. As noted earlier, the WMS4 assesses retention through a combination of recall and recognition procedures. Recall and recognition procedures are used for logical memory 2, verbal paired associates 2, designs 2, and visual reproduction 2 subtests. In addition, verbal paired associates 2 has an optional word recall procedure where the subject is asked to recall words from the word pair list without the constraint of correct word. Pairing and visual reproduction 2 has an optional copy procedure wherein the subject is shown the original stimuli and is asked to replicate the design while it is displayed. Drozdiak et al., 2011. Interim summary. In some ways, the WMS4 is the most radical of all the revisions. Lisak et al., 2012, consider it a whole new test, raising the issue to what extent validity studies of previous versions apply to the present test. It no longer measures verbal working memory. Although it can be administered in significantly less time than the WMS3, but still takes longer to administer and score than the WMS1 and WMSR. For the first time, the test can be administered by a tablet in an interactive fashion. The comparability of tablet administration compared to traditional paper and pencil administration is open to debate. To the best of this writer's knowledge, most all of the factor analysis student guides of the WMS4 to date have been based on the traditional administration method. Tablet administration changes the stimulus value of the test, and likely what it measures. Like its immediate predecessor, the WMS4 allows the clinician to calculate a myriad of scales, index, process scores. In a popular guide on how to administer and interpret the test, Drozdiak et al., 2011, lists 56 possible scores. The actual clinical usefulness of these scores to the average, busy clinician in these days of managed care is questionable. Conclusions and recommendations. It has been said that the more things change, the more they stay the same. In some ways, this aphorism applies to the content of the WMS. Looking only at the results of the cited factor analysis studies, it is significant to note that after 3 decades of trying, the WMS still does not measure delayed recall. Although this finding is well known to researchers in the field, it is not known just how well this finding has been disseminated to the clinical community, since even a cursory examination of psychological and neuropsychological reports reveals clinicians talk talk about immediate and delayed recall when reporting WMS findings. In fairness, the WMS is not the only test of memory which suffers this shortcoming. As noted, even such popular tests as the California Verbal Learning Test 2 suffer from this shortcoming. In light of the failure of the WMS and other tests of memory to assess delayed recall, Carroll, 1993, Merck et al., 2013, as validated by Factor Analytic Studies, IT, has been argued that the time has come to abandon this measure until such time it can be reliably demonstrated through carefully controlled research studies. One problem in abandoning the purported measurement of delayed memory is that regardless of its validity based on the results of factor analytic studies, several purported measures of delayed recall are useful for distinguishing various clinical groups. For example, Lezak et al., 2012, note that diminished WMS3 verbal paired associates 2 scores from the WMS3 statistically distinguished between patients with temporal lobe epilepsy who had left or right seizure foci, and Alzheimer's patients characteristically perform poorly on logical memory too. Since the WMS has been in use for over 75 years, there has been a large amount of research on how various scales and indices correlate with various clinical groups, such as those with Alzheimer's, Huntington's, epilepsy, and other types of brain impairment. 248p et al. Kent. Pearson Assessments has advocated for the continued use of the immediate and delayed indexes, after acknowledging that factor analytic studies have failed to validate these indexes, apparently for the aforementioned reason, that despite the failure of factor analytic studies to validate the immediate and delayed indexes, research has demonstrated the clinical utility of the indexes. Delayed recall measures, as currently clinically conceptualized, are more or less synonymous with long-term or permanent memory storage, Baddeley, Isay, and Anderson, 2009. According to Lezak et al., 2012, consolidation can occur immediately or take a considerable amount of time. Consolidation is a process. The authors describe a type of short-term memory that can be distinguished from immediate memory in that it lasts from an hour or so to 1 or 2 days, longer than a reverberating circuit could be maintained by active rehearsal. They describe this process as an intermediate step, and it has also been described as an intermediate phase, Trugowen, Rucker, and McDermott, 1971, or intermediate memory, Rucker, 1972. It appears that when tests purport to assess delayed recall, they actually are assessing the intermediate step or intermediate memory, since most measures of delayed recall are customarily assessed 25 to 35 minutes after tests of immediate recall have been administered. Recommend Davion 1. Based on the aforementioned analysis, it is recommended that the delayed recall index be renamed the intermediate recall or memory index. On the surface, the WMS has been measuring the right things since its beginning, with the exception of the WMS1 that did not assess delayed recall. All for science have recognized the need for screening the patient for motor and sensory competence, language problems, and attention and orientation. All versions have assessed what we presently would call short-term and working memory. With the exception of the WMS4, all versions assessed verbal working memory through digit span, the ability to encode and recall verbally presented logically related material through logical memory, and the ability to form new associations through verbal paired associ. Atesh. With the exception of digit span, all subtests which were introduced in the WMS1 have remained part of the core battery, although they have vacillated from revision to revision as to whether they are optional. Although all 4 subtests have undergone changes in their content, scoring, and administration over time, the essence of what Wechsler was trying to measure with his original battery, and to some extent, with his 1917 battery, remains remarkably unchanged. In looking at the last 2 revisions, it is remarkable how many new subtests have been eliminated and added. The addition and elimination of so many subtests suggests that these measures were not properly vetted during the standardization process. If history repeats, it is anticipated that several of the new subtests will not survive to the next revision. The subtests which have survived nearly all iterations of the WMS are logical memory, verbal paired associ Atesh, digit span, visual reproduction, mental control, personal and current information. These are also the subtests that appear to have been most widely studied across time, since they are repeatedly referenced by such authorities as Lezak in all editions of her classic textbook of neuropsychology. They are the essence of the WMS, despite the fact that the most recent revision dropped the verbal digit span subtest. Nearly all factor analytic studies of the 4 versions of the WMS have identified 4 factors relating to attention and concentration and working memory and learning and memory. Recommendation 2. Based on the above analysis, it is recommended that the core of the next revision include the aforementioned subtests, including digit span. Along with this, it is suggested the test publisher provide extensive documentation regarding the known correlates between the aforementioned subtests and various clinical groups to assist future clinicians and researchers. As noted, the amount of time it takes to administer and score the WMS has been of concern to many clinicians, since in the last two revisions numerous new subtests have been added and scoring has become increasingly complex. Concern was expressed regarding the large number of questionable scores that can be derived from the WMS 3 and 4. Recommendation 3. Based on the aforementioned information, it is recommended that the test battery be shortened, if possible, to be more patient and clinician friendly. Ideally, testing, interpretation, and score. IMG should take no more than an hour and one half. In addition, interpretation should be made more explicit and straightforward. Repeated concerns have been expressed that none of the versions of the WMS has been anchored in an explicit neuropsychological memory theory or model, consistent with evidence-based practice. Recommendation 4. It is therefore recommended that the next revision be anchored in an explicit neuropsychological theory or model of memory. As noted, there has been ongoing concern about how little useful information the WMS technical manuals have presented about the test use with various clinical groups. The data which have been presented are frequently based on heterogeneous clinical groups of Applied Neuropsychology, Adult 249. Small size, and which are often samples of convenience. In light of the popularity of the WMS, the resources available to the publisher, and the amount of research which has been generated on various subtests from the WMS since 1945, this shortcoming should be addressed in the next revision. Recommendation 5. It is recommended that the technical manual for the next revision contain extensive useful information on how pertinent, well-defined, clinical groups of adequate size, N1/4 50 or more, perform on the new instrument. The importance of assessing prospective memory is increasingly being recognized as an essential component of an adequate evaluation of seniors who have suspected cognitive impairment, and people suspected of suffering from frontal lobe damage. Lezak et al., 2012. Recommendation 6. It is recommended the next version of the WMS contain well-validated measures of prospective memory, since this capacity is essential to the adaptive functioning. The last revision of the WMS does not have an alternate form, which would be useful for test retesting. Purposes. Recommendation 7. It is recommended the next revision of the WMS include a well-validated alternate form. The importance of assessing effort and validity is increasingly being recognized as a necessary standard component for all neuropsychological evaluations. Larrabee, 2015. Recommendation 8. It is recommended that the next revision of the WMS contain well-validated measures of effort and test validity. In summary, the WMS has a long history and has been in continuous use since 1945. It has been revised 3 times in roughly the past 3 decades. As a result of its widespread use in research and clinical domains, a massive amount of information regarding the scale has accumulated. Nearly all revisions of the WMS have suffered from the same aforementioned problems. It is likely a new revision of the instrument will appear in the next 5 years. It is hoped that the next revision will not continue to suffer the shortcomings of those that have come before it. References. Ardila, A., 1999. A Neuropsychological Approach to Intelligence. Neuropsychology Review, 9, 117 to 136. Valley, A. D. Allen, R. J. and Hitch, G. Patterns of memory, a normative taxonomy of the wide range. Assessment of memory and learning, second, RAM 2, asterisk. Thomas M. 2 Department of Abstract. Memory is arguably the most important function of cognition. When left undetected, memory impairments are linked to lifelong underachievement and negative social consequences. Given that the construct of memory is multidimensional, the current study examined patterns of multiple indicators associated with memory across individuals ranging in age from 5 to 85 years who had been administered the wide range assessment of memory and learning, second edition, round 2. Multi-stage cluster analysis with independent age replications was used to empirically identify normative profiles in a sample of n equals 1,172, typically developing individuals. This procedure considered how various indicators of memory operate in concert by accounting for the nonlinear multivariate relationships among them. Results supported 9 common, or core, profile types that satisfy all formal heuristic and statistical criteria, including complete coverage, satisfactory within type homogeneity, between type dissimilarity, and replicability. A summary of the defining characteristics for each profile is provided. Genes, 2008, 14, 869 to 877. Keywords: cluster analysis, multivariate analysis, neuropsychological tests, data interpretation, adolescent risk factors, memory deficits. Introduction. Arguably the most important of all cognitive abilities, memory can be defined as the means by which individuals retain and draw on past experiences to use that information in the present. Tolving, 2000. Within the past 40 years, several competing theoretical models of this research is part of a doctoral dissertation completed at the University of Virginia. An earlier version of this study was presented at the annual meeting of the International Neuropsychological Society, Waikoloa, Hawaii, February 9, 2008. The authors wish to thank Shikha Pham, Bruce Ganseder, and Ronald Reed for their helpful suggestions, and Kristen E. Adalian, Jeremy J. Lamaka, and Michael P. Stone for their invaluable contributions to the study. There are no financial relationships associated with these results that may reflect a conflict of interest or be perceived to reflect a conflict of interest. This project was not supported by extramural funding. Correspondence and reprint requests to Thomas M. Atkinson, Memorial Sloan Kettering Cancer Center, Health Outcomes Research Group, 307 East 63rd Street, 2nd floor, New York, 10065. Atkinside at mskcc.org. HHS Public Access. Author manuscript J. in Neuropsychol SOC author manuscript. Available in PMC September 1st, 2017. Published in final edited form as J. in Neuropsychol SOC 2008 September 14, 5869 to 877. DOI 10.1017/S13556177080811137. Author manuscript. Author manuscript. Author manuscript. Author manuscript. Memory have emerged, including the multi-store model, MS, Atkinson and Shiffrin, 1968, the levels of processing model, LOP, Craig and Lockhart, 1972, working memory models, WM, Baddeley and Hitch, 1974, and the Multiple Memory Systems Framework, MMS, Tolving, 1972. Regardless of the memory model to which one subscribes, it is clear that impairments in any of the identified indicators of normal memory performance place children and adults at risk in terms of their ability to succeed academically. Deficits have been associated with poor mathematical performance, Holmes and Adams, 2006, impairment in visual scanning abilities, Schwann, 1982, problems with attention, Rutledge, 2006, difficulties in new language/vocabulary acquisition, Alloway et al., 2005a, struggles with categorization, Ashby and O'Brien, 2005, and reading difficulties, Swanson and Howard, 2005. When left undiagnosed, memory deficiencies minimally lead to frustration in the child and disengagement from their daily school experiences. Educators and clinicians have several measurement options at their disposal when attempting to identify potential memory deficits. The Wide Range Assessment of Memory and Learning, RAM, Schieslow and Adams, 1990, was recently identified in a survey of clinical neuropsychologists as being one of the most commonly used neuropsychological instruments, Raven et al., 2005. The RAM is unique in its attempt to meet the perceived clinical need for a measure that is sensitive to changes in memory and learning in children throughout their stages of development, is consistent with current theoretical measures of memory, and includes a sufficient number of educationally relevant and simulating tasks, Schieslow and Adams, 1990. Recognizing the lack of consensus on a widely accepted model of memory, the RAM was influenced by cognitive, neuropsychological, and developmental traditions, Schieslow and Adams, 1990. This allowed for assessment results to be interpreted within several theoretical frameworks. Miller et al., 1996, including the MMS and the MS models of memory. More recently, the Wide Range Assessment of Memory and Learning, 2nd edition, RAM2, Schieslow and Adams, 2003, entered the market, extending the useful assessment age of the RAM from 5 to 17 years to 5 to 85 years of age. The RAM2 is largely an update of the original RAM that also provides clinicians with a broader menu of optional subtests. While the assessment of an individual's performance on these measures is an important first step in evaluating potential memory deficits, memory is a multivariate phenomenon that requires joint consideration of how these processes operate in combination rather than in isolation. Although each of the major models of memory referenced above differ with respect to the processes believed to be responsible for memory, all of the systems are complex in the sense that they posit an interconnected network of mechanisms that operate well in concert among individuals with successful memory capabilities. In the same way, it is likely that individuals will demonstrate different patterns of strengths and weaknesses across measures of different memory functions. As a result, it is important to develop models that integrate the full network of relationships that exist among these abilities to investigate their joint occurrence. The primary purpose of this work is to provide an integrated interpretive framework for evaluating an individual's profile configurations on them. Atkinson et al. Page 2. J. Ig Neuropsychol SOC author manuscript, available in PMC September 1st, 2017. Author manuscript. Author manuscript. Author manuscript. Author manuscript. 6 primary subtests of the RAM2 that serve as measures of verbal memory, visual memory, and attention/concentration. In the present study, we use the person-oriented approach of cluster analysis with a large sample of typically developing individuals ranging from 5 to 85 years of age to identify a normative taxonomy of the most common subtest profiles in the RAM2, and then determine whether a mixed clinical sample manifested patterns associated with these profiles. Cluster analysis has been used throughout numerous disciplines to understand the nature of individual differences related to dyslexia, Sachs et al., 1985, language, Bachman et al., 1988, Fagans and Applebaum, 1986, Spies et al., 1999, and learning disabilities, Connell et al., 1997, McKinney and Spies, 1986, Spies et al., 1985. This procedure allowed us to account for the heterogeneous nature of memory functioning and identify homogeneous subgroups that display similar patterns of strengths and weaknesses across these variables that can be used as a normative framework. This is an important first step in evaluating whether a given profile configuration is common or unique. Profiles are integrated sets of scores that are defined by 3 elements: level, shape, and scatter, Cronbach and Gleiser, 1953. Treating test scores as integrated profiles provides many benefits. Most notable is that multivariate methods of evaluating profiles account for the full network of relationships among abilities, Sternberg, 1984, and provide greater insight into the nature and complexity of human ability, thereby providing greater diagnostic precision, Flooding et al., 1997. Cross-validation was incorporated into the analysis, and the internal and external validity of the resulting profiles was also investigated. Method. Participants. Data from the RAM2 standardization sample were used for the primary analysis of identifying normative profile configurations. The 1172 individuals, 47% males, ranged from 5 to 85 years of age and equals 34.83, and were distributed as 5 to 10 years, 33.4%, 11 to 20 years, 16.6%, 21 to 40 years, 10.2%, 41 to 60 years, 11.2%, and over 60 years of age, 28.7%. Test sites were concentrated in 4 geographic regions of the United States: Northeast, 19%, South, 34.4%, North Central, 22.6%, and West, 24%. An effort was made to mirror as closely as possible the 2001 United States Census on the following variables, listed in order of priority: gender, race/ethnicity, African American, 9.6%, Caucasian, 75.1%, Hispanic, 9.6%, and other, 4.8%, and educational attainment, college and higher, 22.4%, some college, 27.6%, high school graduate, 34.1%, and less than high school, 15.9%. Reported parental education, i.e., the higher level of the mother or father, was used for stratification purposes for participants younger than 17 years of age. Only those that met the census targets in each testing site were selected for standardization. No other exclusion criteria were specified. The study was approved by the University of Virginia Institutional Review Board. Atkinson et al. Page 3. J. Ig Neuropsychol SOC author manuscript, available in PMC September 1st, 2017. Author manuscript. Author manuscript. Author manuscript. Author manuscript. Measure. The Ramble 2 consists of 17 subtests, each yielding scaled scores ranging from 1 to 19. Given that the scaling of variables entering a clustering algorithm can influence their relative contributions in the final solution, all measures were standardized to the same t-score metric, n equals 50, SD equals 10, based on age-specific technical manual conversion tables. 6 of these subtests comprise a core group that can be combined to yield 3 primary indices: verbal memory, VBM, visual memory, VIM, and attention/concentration, AC. The remaining 11 subtests, including delayed recall tasks, as well as separate working memory, verbal recognition, and visual recognition indices, are optional and can be used to provide supplemental information about the memory function of an individual. The focus of the current study was on the 6 core subtests that are most often administered during individual clinical evaluations. The brief descriptions of the 3 primary indices and their underlying subtests that follow were obtained from the Ramble 2 Administration and Technical Manual, Schieslow and Adams, 2003. Verbal memory, VBM, focuses on how novel verbal information is processed and recalled and is composed of 2 core subtests: story memory and verbal learning. In story memory, a participant is read 2 short stories and is immediately asked to recall as many aspects of the reading passages as possible. Individuals aged 8 years or younger are read stories consisting of 25 and 36 separate aspects, while those 9 or older are read stories containing 36 and 40 aspects, respectively. Verbal learning involves 4 repeated trials of an experimenter orally presenting a participant with a list of simple words, followed by immediate recall. The word list consists of 13 items for individuals 8 years or younger and 16 items for those 9 or older. Visual memory, VIM, is hypothesized to measure learning and memory of recently presented visual stimuli. The core subtests for this factor are design memory and picture memory. Design memory involves the 5S exposure of a participant to a series of 5 cards with various geometric forms. After this brief exposure, the individual is asked to draw all aspects of the image that they are able to recall. In picture memory, participants are asked to identify changes that have been made to 4 separate common, yet complex visual images after a 10S exposure to each image. Attention/concentration, AC, measures the same named abilities through the use of 2 core subtests: finger windows and number letter. The finger window subtest presents participants with a vertically resting card containing asymmetrically located holes. In each trial, the examiner demonstrates a pattern of placing a pencil eraser in a sequence of holes and then asks the individual to duplicate the sequence by placing their finger in each hole according to the order of presentation. The length of the sequence of holes increases after each trial. The number letter subtest is similar to a digit span task. Participants are orally presented with sequences of alternating numbers and letters and then asked to recall this information in the order it was presented. Psychometric properties of the 6 primary subtests are well documented and favorable, Schieslow and Adams, 2003. Internal consistency measures were in the high to excellent range, 0.86, 0.93, for the majority of subtests. Confirmatory factor analyses, CFA, demonstrated. Atkinson et al. Page 4. J. Inc. Neuropsychol SOC author manuscript, available in PMC September 1st, 2017. Author manuscript. Author manuscript. Author manuscript. Author manuscript. That, consistent with the hypothesized framework, a 3-factor model best represents the 6 core subtests. Multi-group structural analyses provided evidence that the 3-factor solution was invariant across groups reflecting gender, ethnicity, age, and level of education. In addition, various subtests of the Ramble 2 demonstrated an acceptable degree of correlation with other instruments designed for the measurement of memory, including the Wechsler Memory Scale 3, R equals 0.60, Children's Memory Scale, R equals 0.49, Test of Memory and Learning, R equals 0.69, the California Verbal Learning Test, R equals 0.64, and the California Verbal Learning Test 2, R equals 0.68. Clustering strategy. The clustering strategy we adopted was similar to the one used elsewhere for identifying normative profiles. Ludding and McDermott, 1990, Ludding et al., 1997, Connell et al., 1997, as described in McDermott, 1998. This procedure involves 3 steps. In the first step, Ward's, 1963, hierarchical agglomerative procedure was performed on a Euclidean distance matrix that is sensitive to level, shape, and scatter. Ward's method has been shown to outperform alternative methods in terms of minimizing profile overlap, Bain et al., 1980, and to be the most efficient means by which to recover known taxonomic structure in a population exhibiting variation, Kuiper and Fisher, 1975. In this first step, the total sample, n equals 1,172, was divided into age-level partitions to form 5 blocks, consistent with the predefined age groups of the round 2, i.e., 5 to 10, 11 to 20, 21 to 40, 41 to 60, and over 61. Schieslow and Adams, 2003, thereby allowing for an internal age-based replication analysis. Decisions regarding the number of clusters to retain within each of the 5 samples were based on several indices: pseudo-F, Kalinsky and Tarabas, 1985, pseudo-T2, Duda and Hart, 1973, R2, inspection of the agglomeration index for each subgroup as well as the agglomeration history within each subgroup, the coherence of the resulting clusters, and the degree of replicability of clusters across subgroups, Crockett et al., 2006. This step also used a trim procedure that removed a maximum of 2% of the outlier cases from consideration in the analysis, McDermott, 1998. Information from the clusters identified in Step 1 was pooled to form an overall similarity matrix that was used for Step 2. Thus, Step 2 clustering began with a proximity matrix whose diagonal elements held error sums of squares, ESS, statistic values for respective Step 1 clusters, with off-diagonal elements corresponding to potential ESSs for merging each pair of first-stage clusters. Ward's method was used on the resulting similarity matrix from Step 1 to assess the extent to which cluster profiles from subsamples of the data matched those found for the total sample, i.e., replication. Each of the aforementioned statistical indices was again considered when determining how many clusters to retain at Step 2. Steps 1 and 2 led to the identification of 9 clusters. Clusters 8 and 9 yielded replication rates of 60% and 80%, respectively. The remaining 7 clusters demonstrated replication rates of 100%. Table 1. The replication rate of 80% indicates that profile 9 was also identified in 4 of the 5 subsamples, whereas profiles demonstrating 100% replication rates were found to emerge in all 5 subsamples of Step 1. Group centroids from the Step 2 solution served as starting seeds for the Stage 3 iterative partitioning analysis conducted using K-means passes. K-means cluster analysis makes use. Atkinson et al. Page 5. J. Ig Neuropsychol SOC author manuscript, available in PMC September 1st, 2017. Author manuscript. Author manuscript. Author manuscript. Author manuscript. Of an iterative procedure where individuals are assigned to core subgroup membership based upon their smallest Euclidean distance to each subsequent cluster centroid, Eng et al., 2000, Jones et al., 2006. This third step was necessary because hierarchical agglomerative procedures, Steps 1 and 2, do not allow subjects to shift clusters after their original assignment, despite the fact that they may fit better in a different profile later in the solution. By contrast, iterative partitioning procedures allow subjects to migrate to neighboring clusters, following identification of the number of suspected clusters, Steps 1 and 2, and generally result in tighter solutions. Results. Mean profile configurations for the resulting 9 cluster solution are presented in Table 2. The 9 profiles represent the natural variations of individual memory disparity and are typical of what we would expect among the general population. Table 1 provides other psychometric properties for each profile. The final cluster solution from Step 3 was required to retain the dual properties of internal cohesion and external isolation, Allendorfer and Flashfield, 1984. Both internal cohesion and external isolation address the issue of internal validity. Internal cohesion refers to the tightness of a cluster, or the closeness of objects around a cluster centroid. External isolation refers to the distance between clusters in multivariate space. Thus, subjects within a given cluster should be similar to one another, whereas clusters composed of homogeneous individuals should be distinct from one another. The average age coefficient, Tryon and Bailey, 1970, across profiles satisfied a priori. Expectations for internal cluster cohesion greater than or equal to 0.60, average age equals 0.75, thereby providing evidence in support of homogeneous within cluster representation. In addition, the average R.P. Patel, 1949, across profiles also satisfied a priori expectation in support of external isolation less than 0.40, average R.P. equals 0.38. Profile descriptions. In the descriptions that follow, we present a synthesis of information reported in Tables 2 and 3 pertaining to the group averages demonstrated by these profiles and associated demographic features. We have chosen to name each group according to that feature of functioning that appears to distinguish it from the other groups. Thus, the names below reflect a distinguishing feature and by implication also reflect average functioning in the other domains assessed. Profile names are provided to highlight relative strengths and weaknesses that were found through empirical methods as a way of differentiating among individuals that are not known to be at risk. The summaries below also take into consideration the demographic factors of ethnicity, education level, and age. For each demographic category, observed percentages were compared with expected values based on the composition of the overall sample through methods of standard error of proportional differences test. An alpha level of 0.006, 0.05/9 was used to adjust for multiple comparisons and reduce the likelihood of type 1 error. Observed percentages of males and females did not statistically differ from expected percentages in any of the 9 identified profiles. 1. Above average memory skills, prevalence equals 12%. This cluster demonstrated a relatively flat above average profile across each of the 6 memory indicators. Fewer than. Atkinson et al. Page 6. J. 8 Neuropsychol SOC author manuscript, available in PMC September 1st, 2017. Author manuscript. Author manuscript. Author manuscript. Author manuscript. Half of the anticipated African American and Hispanic participants were present in this profile. There were over 2 times more individuals with college and higher levels of education than expected, and a significantly fewer than expected number of individuals reported that high school graduation or less than high school was their highest education level. 2. Above average attention/concentration, prevalence equals 8.9%. This pattern demonstrated the lowest rate of prevalence. Individuals in profile 2 exhibited above average scores on the subtests that comprise the attention/concentration factor, i.e., finger windows and number letters. Half of the expected African American participants and less than a quarter of the anticipated Hispanics were found in this profile. While significantly fewer members of this profile were members of the high school graduate and less than high school groups, a greater than expected proportion of participants had a beyond college level education. In addition, there were significantly more members of the 21 to 40 and 41 to 60-year-old age groups. 3. Above average verbal and visual memory, prevalence equals 10%. Members had above average scores on the 4 subtests, i.e., story memory, verbal learning, design memory, and picture memory, underlying the verbal and visual memory factors. A smaller concentration of Hispanics and participants in the other ethnicity category were found in this profile than was anticipated. Fewer than expected number of participants in this profile reported having attained less than a high school diploma, and a significantly higher proportion of participants were found in the 41 to 60-year-old age block relative to the overall sample. 4. Above average visual memory, prevalence equals 11.2%. Visual memory was elevated among members of this profile as evidenced by somewhat above average performance on design memory and picture memory. Significantly fewer individuals obtained a college or higher level of education. There were more members of the 11 to 20-year-old age group, and fewer members of the 21 to 60-year-old age groups than expected. Ethnicity composition met expectations in this profile. 5. Above average verbal memory with depressed design memory, prevalence equals 11.4%. Individuals in profile 5 demonstrated higher scores on the story memory and verbal learning, measures of verbal memory, and performed below average on design memory. This profile consisted of a lower concentration of African American and Hispanic participants than was projected. Age groups were represented in proportion to the overall sample. However, significantly fewer individuals with this profile reported not having attained a high school diploma. 6. Variable memory skills, prevalence equals 9.1%. Members of this profile were somewhat above average on one index of each of the 3 factors, verbal learning, design memory, and finger windows, and somewhat below average on the remaining index of the 3 factors, story memory, picture memory, and number letter. A higher than expected proportion of participants in the other ethnicity category was found in this profile. A large percentage of participants reported having less than a high school education level, 20.4%. Atkinson et al. Page 7. J. 8 Neuropsychol SOC author manuscript, available in PMC September 1st, 2017. Author manuscript. Author manuscript. Author manuscript. Author manuscript. When compared with the composition of the standardization sample, and there was a less than anticipated concentration of participants older than 61 years of age in this profile. 7. Slightly below average memory with elevated number letter skills, prevalence equals 13.3%. Ethnicity and education level distributions within this profile were within expectation. However, fewer individuals were members of the 11 to 20-year-old age group. 8. Slightly below average memory with elevated picture memory skills, prevalence equals 13.3%. Significantly more African Americans, Hispanics, and members of the other ethnicity category were found in this profile, while there was a fewer than expected percentage of Caucasians. Less than half of the expected percentage of participants in this profile had attained at least a college degree, while a greater proportion had yet to attain a high school diploma. Age distributions within this profile were consistent with expected distributions. 9. Below average memory skills. Prevalence equals 10.8%. This profile configuration was representative of generally below average performance on measures of memory. A larger proportion of African Americans, Hispanics, and those in the other ethnicity category were found in this profile than was expected. More than twice the expected proportion of participants with this profile attained less than a high school diploma, while significantly less had attended college or at least completed a college degree. Age group distributions were consistent with expectations. Profile stability. Profile stability was examined with N equals 142 participants, the majority of which were included in the original normative standardization sample and were also retested following a period of time, N equals 73.5 days, SD equals 63.9 days. To objectively compare the normative core profiles obtained from the standardization sample with those in the retested sample, it was necessary to select a statistical strategy for evaluating pattern similarity. The accuracy of two procedures for evaluating pattern similarity was first examined within the normative sample, N equals 1,172, to determine which approach yielded the highest classification rates when cluster memberships were known. Patel's RP technique, 1949, revealed pattern similarity return rates of 84.4%, whereas the distance measure, D2, 1952, of Osgood and Susi, 1952, yielded somewhat more favorable return rates of 97.7%. Consequently, Osgood and Susi's D2 was used with the retest sample, N equals 142, to gauge profile stability. 65 of the 142 participants, 65/142 equals 45.8%, were classified to the same profile configuration based on their initial testing and subsequent follow-up. This stability estimate represents a material increase over what would be expected by chance, 12.4%, assignment across the 9 profiles. In addition, it is important to note that there was not a statistically significant difference in the number of retest days between participants that were found to have the same profile configurations at both testing occasions, M days equals 81.06, and those that did not, M days equals 67.05, T, 140, equals minus 1.30, P equals 0.19. Atkinson et al. Page 8. J. Neuropsychol SOC author manuscript, available in PMC September 1st, 2017. Author manuscript. Author manuscript. Author manuscript. Author manuscript. Discussion. Despite the ongoing debate as to which theoretical model of memory is most representative of the underlying mechanisms of the construct, the importance of this cognitive ability in everyday function is unquestionable. When left undetected, memory impairments are linked to lifelong underachievement and negative social consequences. Alloway et al., 2005b, Kalu et al., 2005, Swanson and Howard, 2005. The RAM2 was designed to be a comprehensive tool to be used in the detection of clinically meaningful deficiencies in memory ability throughout the lifespan, Schieslow and Adams, 2003. The purpose of the present study was to identify a normative taxonomy of profiles likely to be found among typically developing individuals. 9 normative patterns of memory were identified through a multivariate model that simultaneously considered multiple measures of memory, reflecting a range of underlying constructs related to verbal, visual, and attention slash. Concentration abilities. Profiles were defined in terms of patterns of relative strength and weaknesses on these assessments. The 6 subtests of the RAM2 core battery, on which the profiles were obtained, have been shown to measure 3 components of memory: verbal memory, visual memory, and attention slash concentration, Schieslow and Adams, 2003. As such, the normative profiles presented here may be particularly useful for differentiating between normal and other clinical groups than were the focus of the current investigation. For example, a study of memory performance in patients experiencing severe depression demonstrated differences in performance on measures of verbal memory, visual memory, and attention slash concentration, Hin et al., 2006. Morse and Rice, 2005, treated verbal memory, visual memory, and attention and concentration as separate systems in an investigation of memory in postmenopausal women. Patient outcomes on measures of verbal memory, visual memory, and attention slash concentration were among several dimensions examined in a study of the relationship between educational attainment and cognitive performance in a group of individuals with subarachnoid hemorrhage, Nakatina, 2006. Examination of profile configurations of these and other known clinical groups would be important next steps for extending the clinical utility of profile analyses as related to memory. In addition, it may be useful to revisit this analysis and include the RAM2 optional subtests from the 3 memory components, as well as the supplemental areas of working memory, verbal recognition, and visual recognition to capture a somewhat more global understanding of memory and learning in an individual. It should be pointed out that while the present study may appear to indicate that individuals belonging to a particular demographic, e.g., age group, may specifically exhibit higher performance than others in the sample, caution should be used when interpreting these relationships. While such comparisons could prove as useful for clinicians, future research is needed before making specific comparisons between demographic groups on any of the identified RAM2 profiles. This is particularly true when making profile comparisons based upon ethnicity, given the small sample sizes for the African American and Hispanic groups in relation to the Caucasian participants. Atkinson et al. Page 9. J. Ig Neuropsychol SOC author manuscript, available in PMC September 1st, 2017. Author manuscript. Author manuscript. Author manuscript. Author manuscript. To meet analysis requirements and to remain consistent with methodology during test standardization, the original 15 age groups, i.e., ages 5, 6, 7, 8, 9 to 10, 11 to 13, 14 to 17, 18 to 24, 25 to 39, 40 to 54, 55 to 64, 65 to 69, 70 to 74, 75 to 79, and over 80 were collapsed into 5 blocks. Combining these age groups may obscure the ability to detect differences in profiles throughout the lifespan. To recover potentially useful information related to age differences, a larger sample should be collected with at least 150 to 200 participants in each age group. It should be pointed out that sample size did not impact the overall magnitude of the cluster analysis in this study, as all internal cohesion, external isolation, and a priori replication requirements were met. The present results may assist clinicians during the process of instrument selection in memory assessment. Despite somewhat frequent use of the original RAM, Raven et al., 2005, the RAM2 has been sparsely mentioned in the current literature, Hall, 2006, 2007, Hartman, 2007, Shaver, 2005. Consequentially, it is important to establish the psychometric qualities of this instrument to help clinicians determine whether this test is a viable alternative for the existing methods of memory assessment. As opposed to some of the more established instruments, i.e., CFT, CDLTC, CMS, the RAM2 is currently the only measure of memory that can be administered across the lifespan, Schieflo and Adams, 2003. To compete with the features of other memory assessment instruments, as well as provide clinicians with desired supplemental information, several optional subtests are available to assess delayed recall, verbal and visual recognition, as well as working memory. In addition, results of the present study were consistent with a cluster analysis of the CDLT. See Donders, 1999. To further compare across memory assessment instruments, it would be helpful to identify common profiles in each of these tools and determine sensitivity to the detection of clinical impairment. The obtained normative taxonomy of profiles provides clinicians with a useful tool for evaluating whether observed score patterns on the RAM2 are deviant or simply reflect normal subtest score variation. Through direct comparisons with results from the present study, individuals that would be typically identified as having memory or learning deficits based upon normative information may, in fact, be scoring within a given normal profile. It is suggested that future test standardizations incorporate cluster analysis to provide clinicians with additional pieces of information for identifying potential deficiencies in abilities. Finally, it is important to provide some additional context for the obtained profile stability analysis conducted on the 142 retest participants. Although we are encouraged by the 45.8% return rate that was materially greater than what would be expected by chance, i.e., 12.4%, the fact remains that over half of the participants migrated from their original profile type on subsequent evaluation. Unfortunately, the assessment of memory and learning does not lend itself well to score consistency in a longitudinal sense. Schieflo and Adams, 2003, discussed this point in the RAM2 Technical Manual. With memory tests, there is an inherent problem with measuring stability in that the test itself is predicated on the retention of specific material presented at the time of testing. The giving of the test a second time presents more opportunity for learning. Atkinson et al. Page 10. J. Ig Neuropsychol SOC author manuscript, available in PMC September 1st, 2017. Author manuscript. Author manuscript. Author manuscript. Author manuscript. And, therefore, can contaminate the original purpose of the testing, thus spoiling the stability measurement. With measurements of reasoning, achievement, or other cognitive abilities, this effect is not as severe because the intent of these measures is not learning per se, but the assessment of what has been learned outside the test situation and applied in some way to the test content. Page 100. Retest estimates for the 6 RAM 2 subtests that serve as the basis for cluster formation ranged from 0.53 to 0.78 in the standardization sample, Schieslow and Adams, 2003. In our retest sample, the majority of participants' scores across the 6 measures increased from the first to second testing, 56%, while others decreased, 23.35%, or remained the same, 18.65%. Consequently, clinicians are encouraged to evaluate individual profile configurations relative to the normative subtypes identified here, based on first evaluations to capitalize on the novelty of the client experience with respect to exam content. References: Aldenderfer, M.S., Flashfield, R.K. Cluster Analysis. Beverly Hills, California,